Hello and welcome to a Clinical Conversations Roundtable on the career choices that newly minted internists have been making over the past decade. According to a report in the Annals of Internal Medicine, and I'm quoting, by 2018, 71% of newly certified general internists practiced as hospitalists, compared with only 8% practicing as outpatient-only physicians, end quote. We've gathered a group of young internists to talk about this shift. And let me welcome our guests. Dr. Holland Kaplan of Baylor College of Medicine and Ben Taub General Hospital, Dr. Francis Yu of Harvard Medical School and the Cambridge Health Alliance, Dr. Sneha Shah of the University of Colorado and the VA Medical Center there, Dr. Stephanie Bronthal of Brown University and Women and Infants Hospital, and Dr. Megan Rutter, who does primary care at BWH Fish Center for Women's Health as part of the Mass General Brigham Group. Welcome, and thanks for being here. I hope we can examine the reasons for the popularity of the hospitalist specialty among new internists and make some predictions about where it will lead. So let's first establish some definitions. Hospitalists practice almost exclusively in hospitals, while mixed practice physicians see patients both outside and inside the hospital. And outpatient-only physicians, well, they see only outpatients. The Annals paper points out that as a percentage of general internists, both hospitalists and outpatient-only types increased by at least a third between 2008 and 2018. But mixed practice types, the people you used to see carrying little black bags and visiting their patients in the hospitals, they declined over 50%. So the question for you all, young internists, is what's caused this shift?
I can go ahead and jump in first.
Dr. Kaplan.
I personally, when I kind of was deciding between inpatient and outpatient medicine, I felt like there was actually too much information to be able to have a good understanding of both inpatient and outpatient general medicine and be able to practice solid evidence-based medicine in both at the same time. There's just so much information in these specialties now.
To add to Dr. Kaplan's point,
Dr. Yu,
is that the field of hospital medicine is relatively new compared to other fields in medicine. And really recognizing that there's a difference in practice and medical knowledge needed for both the inpatient and the outpatient setting, which leads to, the Society of Hospital Medicine actually thinking about creating hospital medicine boards that will be separate from, outpatient practice.
Dr. Shah.
Joe, I would imagine there's a fair bit of knowledge that we have in terms of escalating care to an ICU level, escalating care to subspecialty care, and where the line blurs between when somebody comes in with an inpatient problem, let's say a chest pain rule out, when should I call a cardiologist? Whereas an outpatient physician may simply be admitting them to the hospital. It's really my job to know when I should call a subspecialist. And then I think outpatient physicians do a fair bit of this where they're coordinating a patient's sort of social work type care. And in the hospital medicine setting, we do that quite a bit, knowing when the patient needs to go to a subacute rehab facility, when they might need long-term care, and what the best disposition plans are. And I think all of this is becoming more and more in the realm of what a hospitalist needs to know on their day-to-day basis in working with their interdisciplinary staff, care managers, social workers, et cetera. And I think we do that a lot more in our day-to-day practice.
So it's a matter of the amount of resources available to the hospitalist that changes the complexity of medical practice. You have immediate access to those, almost immediate access to those specialists. But here's a question that I've encountered. A relative of mine was admitted to the hospital with a GI bleed, and she has a heart problem as well. And we're getting phone calls from her saying how frustrated she was that she wasn't seeing anybody. And so, Joe, the younger brother goes in and says, all right, let me see what's going on here. And so the next doctor who walked into the room, I said to the doc, who's in charge? And she said to me, oh, we don't work that way. And I went, what? What do you mean you don't work that way? And she said, well, it's problem oriented. And so that there isn't a person who's responsible for the patient's care. Now, I'm sure that the style of practice in your institutions may be very different from that. But on the other hand, this is 3 years ago, and I was wondering, how do you get continuity of care in an environment like that? How, when somebody comes in with high blood pressure or diabetes, who do you follow up with? Dr. Bronthal.
Do you remember in that specific situation, who told you that there was not one person in charge? Because I think that typically how I see the hospitalist role is that hospitalists end up being the primary care physicians of the patient while they are in the hospital. And so the question of continuity of care depends a lot on the pre-hospital care and the access to post-hospital resources. But ultimately, there is really one person or one team who's making the call of when this patient should be admitted and when this patient should be discharged. And that person should be the person who's technically in charge, even if you're in a situation in which there are multiple specialties who practice autonomously when consulted for the patient.
When I was younger, I was a lab technician, and of course I saw all those docs walking around with the little black bags in the hospital, making rounds, and you don't see that much anymore.
Just to add to that, Joe,
Dr. Yu.
I like to kind of push back on that experience because I don't think that is the experience of the majority, or at least I hope not. As hospital medicine physicians, we see people for a vast array of issues. They come in with things like just a fever, and it's our job to figure out and to reason through all the information to figure out, do we need certain specialties involved? How do we reconcile all the recommendations being given? And so I really see hospitalists, as Dr. Bronthal has said, the inpatient primary care physicians who are really teaching, residents, teaching medical students, doing the clinical reasoning, teaching physical exam, the glue that really holds the hospital together in the care that we provide.
Point taken. Dr. Shah.
I sort of think of hospital medicine, I think of hospital medicine as the great synthesizer. Not too infrequently will we get contradicting opinions from different subspecialties. So in the case of, say, your loved one, Joe, GI physicians may have been saying, you need to give this patient more fluids or more blood, whereas cardiology may have been saying you need to diurese this patient. And so it's really up to the hospital medicine provider to gather the information that the different subspecialties are giving, and then ultimately choose the best plan of action for that patient, knowing the entire reason for which they're here and not just the specific organ in which I'm a specialist.
Well, we have Dr. Rudder with us, who sees people as primary care, and you don't. I mean, you recommend that people go to the hospital, but you don't follow them to the hospital.
Yep, that's right. So if there's a patient that I see in my outpatient practice or who calls in, who I think needs to be evaluated in an emergency care setting for consideration of admission, then we have a way to sort of give, not necessarily a warm handoff, but through Epic, because our system, our hospital systems generally all use Epic. We're able to put in an expect note and describe our clinical concern to at least to the emergency medicine team. And I think speaking, you had asked a question a little bit earlier about how do we ensure continuity of care for patients who are followed by, a hospitalist team on the inpatient side. It's not been too long since I've been on that side as a resident. And one thing that I think I've seen residents and hospitalists take great pride in is that handoff. And so that often comes in the form of a discharge summary. And the way that I've seen those done very nicely is providing a concrete list of action items for each member of the outpatient team with whom the hospitalist team expects outpatient follow-up, including the primary care physician. So there's a nice list of tasks for me as well. And And then that gets routed to me at the time of their discharge from the hospital. And then we generally have a nurse pool that looks into each of those discharge summaries, calls the patient, and ensures that they're scheduled for appropriate follow-up, whether that now is a telehealth visit to start or an in-office visit. That's generally how that process works. That breaks down a little bit when we're doing sort of cross-system continuity of care, systems that aren't necessarily integrated into the same EHR. But generally, I've seen it work fairly well for patients within a system that can communicate well.
So we've had a couple of reasons that for the popularity of the hospitalist specialty. Is one of those stable hours, better, guaranteed salary? Are there social and cultural reasons for this, as well as, gee, I have access to a bunch of good specialists? Dr. Kaplan.
I can jump in real quick with a response to that, Joe, to start us off. So I think that I would not say hospitalist medicine necessarily has easy hours. I would say whenever I'm on service at the hospital, I may get there at 6 a.m. I may leave at 7 or 8 p.m. depending on the admission schedule for the day. But one of the things that appealed to me, in addition to just the appeal of general medicine being a field with broad differentials, kind of the intellectual nature of the specialty, fast pace, was that there is this sort of like on-off mentality. So when I'm on, I can completely throw myself into taking care of patients, teaching residents, and just thinking through the problems that my patients have. But when I'm off, I have kind of other interests that I pursue as well. I see ethics consults, I do research, I do teaching. And so that flexibility kind of allows me to be on when I'm in the hospital taking care of patients. And then when I'm off, I don't need to be kind of following up on other patient care tasks. Instead, I can fully focus on the other things that I'm working on. So I think it's a particularly attractive specialty for people who have a variety of interests, so that you can pursue different types of interests that you have.
I think,
Dr. Brownthal.
in addition to that, during residency, so much of our training is inpatient. And I think that all of us on this panel have grown into medicine with career hospitalists as our mentors, as opposed to physicians who did both inpatient and outpatient. I think there are still some hospitals where you admit to different private practice groups, but for the most part, so many of our mentors inpatient, where there's a lot of camaraderie and emotions and intellectual growth, are through hospital medicine. And so when we think of ourselves as general internists, a lot of our identity during residency is consumed in the hospital, and making that shift is really difficult unless we have experiences outpatient, or we have kind of a predisposition to going into outpatient medicine going into residency.
Dr. Yu.
And I think also, to add to that, within the field of hospital medicine, many of us identify as academic hospitalists, meaning clinician educators, where our focus is really to train medical students and residents in the art of the bedside physical exam and clinical reasoning and all the things that we do in the hospital. And I think hospitalists in particular play a large role in the majority of the medical education of many of these trainees. And that really appeals to many of us in terms of the idea of teaching, mentorship, feedback, and being involved in that teaching aspect.
Dr. Rutter, so I was talking about the regularity of the schedule for hospitalists. Maybe you've got the most regular schedule. Is that possible?
In some ways, I think on paper, yes. If you're including sort of my my strict office hours, I think one piece of, and granted, I'm in my first year as a primary care physician full time, but one of the pieces that I struggle with is sort of the opposite of what Dr. Kaplan was mentioning. This feeling of sort of constantly being on. So I receive messages from patients at all hours of the day and night. And increasingly, I think our sort of society is one in which we expect timely responses to electronic, in particular, forms of communication. And so that's something that I struggle with, thinking about that in the context of my job and in delivering high quality clinical care and being the type of provider that I'd like to be for my patients. So in that sense, my off hours don't always feel like off hours, but my office hours are quite regular.
So you get the sense of being, in a sense, always on.
In a sense, I don't know that that's something that it's not necessarily expected by the institution, but I think it is an expectation of patients these days, and it's something that is highly valued and appreciated by patients. And so, that's an area that I'm grappling with, balancing self-care and clinical care.
Dr. Brownthal.
To kind of build on what Dr. Rutter is saying, so I'm currently in a situation where I'm in a general internal medicine fellowship in which I practice outpatient one week and inpatient another week. And oftentimes we actually have the exact setup that many traditional primary care or traditional general internists rather had practiced, where we see our outpatients when they come into the hospital. And I think that sense of needing to be there for the patients and always being on is actually compounded when we have the both outpatient to inpatient continuum, because the patients actually are used to seeing us in both scenarios and able to access our time. And I think that it's wonderful for continuity of care, but that feeling of being always on is actually additionally compounded when we feel a responsibility to know our patients inpatient and outpatient as well, inside and out.
Let me ask a general question about, I mean, you've made your decisions, although some of you may become pathologists later, I don't know, but what was as you were deciding, as you were going through your training, and you've mentioned this before as having been mentored by people who are hospitalists, what was the best advice that you got as a sprouting new internist? Dr. Kaplan.
A piece of advice that I got was to enjoy the bread and butter of whatever specialty you pursue. So enjoy kind of the typical general practice, not the rare cases that you see in whatever specialty or type of practice you pursue. And for me, I was initially interested in subspecializing, but I eventually realized that what I enjoyed most in residency was actually teaching and mentoring medical students. And I also just enjoyed the opportunity to evaluate an undifferentiated patient who had any initial presentation, but who was coming into the hospital, was scared, was sick, and I had the opportunity to be the person who was there for them to kind of get them to a place that they were more comfortable, both in terms of just emotionally, but also medically. And being a hospitalist met all of those kind of needs for me.
I think to add to what Dr. Kaplan mentioned,
Dr. Yu.
One thing that has really stuck with me, and I think, applies to any career, medicine or not, is to try to imagine your career in 3 kind of segments. So early career, middle career, and late career, and try to imagine how your career might evolve. And I think in the field of hospital medicine, it can really evolve to anything that you want it to be. You have a great mix of like clinical work. I have many colleagues that are doing quality improvement, medical education. They are also leaders in the hospital. They can also pursue bench research. And I think the idea that your career can evolve to fit your professional and personal needs really appeals to me. And it makes the job exciting because it's always changing. Being on the forefront of the COVID pandemic, of this whole monkeypox outbreak, we're doing a lot of exciting things in the hospital. Not to say that it's not also as exciting outpatient. But I felt that especially with the COVID-19 pandemic, it's really challenging being a primary care physician. And I really applaud Dr. Rutter for really filling the need, especially in our primary care community, because I just have seen in terms of like televisits and other kind of changes in primary care that it makes it really difficult to provide the high quality outpatient continuity that we come to expect of ourselves.
Dr. Ryder, do you want to respond?
Sure. Yeah. I mean, so I have been practicing in the outpatient setting toward the, within the past year. So I wasn't necessarily at the forefront of the early days where there was so much uncertainty and upheaval. But I will say that I have experienced the explosion of Paxlovid prescribing and other changes to primary care practice in the outpatient setting, which I hadn't been as familiar with as a resident doing primary care, because I did actually take a period of time between residency and my current outpatient practice doing a general internal medicine fellowship that Dr. Brownthal is doing now. But I will say, I think that, just speaking a little bit to some of the changes in primary care practice related to telehealth, I think in a lot of ways we've found that it has been able to enhance care, particularly for patients who are not able or less able to come to in-person appointments. And so vulnerable patients that we might not be able to reach otherwise, this provides a way for us to do that. And there have been a lot of exciting, on the inpatient and outpatient side, technological advances that make us better able to monitor home health, including remote blood pressure monitoring. There are a lot of programs for remote monitoring of cardiovascular health, including patients with heart failure. And then, there's now we sort of have ubiquity of home pulse oximeters and heart rate monitors, and advances, coming up in terms of outpatient cardiac event monitoring. And so I think there's a lot that we're able to do remotely, which is exciting, and hopefully going to sort of help improve health on a population scale. And one of my passions is preventative care. And so I see this as a very exciting time to be in outpatient medicine.
Rudolf Virchow, the founder of cellular pathology back in the 19th century, said medicine's a social science, and I think he's right, and I think that talking with all of you kind of bears that out. So when I was a kid and working in the medical lab 50 years ago, there are all these people who had practices and little black bags and running around the hospital. Look into the future, if you would. What's your prediction about what medicine will be in, say, 25 years? What would you think, Dr. Yu?
I don't know what the future holds, but I do think that I'm hopeful that we'll be able to keep patients out of the hospital. Although I'm an inpatient hospital doctor, my goal is always to try to keep people out of the hospital, because if they're coming to the hospital, that means they're sick enough to need to come to the hospital and to stay in the hospital overnight. Like, our goal is always to work closely with, the primary care doctors, the outpatient teams, even community organizations like Healthcare for the Homeless, to really keep people healthy and to keep people out of the hospital. So, I hope to see in the future some greater collaboration and integration amongst inpatient and outpatient providers.
But that's an interesting answer, Dr. Yu.
I think, just to clarify, I don't think anything will happen to the specialty. It's not just our efforts to keep people healthy, and with those efforts failing, that bring people to the hospital. It's all the social determinants of health, not having access to healthcare, all like those disparities that we have in place that we really need to battle, all the structural things that are affecting people's health. Those are much larger issues to deal with that will continue to be with us. And I suspect people will still need to come to the hospital, but I think we can still do a lot more altogether in keeping people healthy and safe at home, and maybe decreasing the burden of disease.
Is there a question you wish I had asked? Dr. Bronthal.
Internal medicine has become significantly more diverse than it once was. So the doctor with the little black bag that went in and out of the hospital now has a lot of different options, whether it's inpatient, outpatient, academic, private practice, administration, public policy. And so for all of us who choose to stay within the field of general internal medicine, I do think that there certainly are people who keep their identities as either primary care physicians or hospitalists, but most of us identify as internists first, and we see the breadth of possibilities ahead of us. And I think that's what keeps the field so attractive.
Is there a question you're glad I didn't ask, Dr. Yu?
Well, one question I thought you were going to ask is, as a nation, we have such a shortage of primary care physicians, compared to other developed nations, like, for example, Canada, the United Kingdom. Like, what can we be doing better as a medical society or society in general to, increase the number of primary care physicians? Because all of us need primary care physicians, the population does. And it's like that really strong primary care network that keeps people healthy, as Dr. Rutter said, on a population level. So I thought you were going to ask us maybe something along those lines.
Consider the question asked. What is the answer to that? Nurse practitioners have really come to the fore, and not that they're going to replace internists, but they're certainly doing the kind of work in the clinic and making some diagnoses, more so than they were doing when I was watching the people with the little black bags walking around. So are nurse practitioners a way to address this? Dr. Rutter.
I think that this issue needs to be addressed at many different levels. I think it's more than just a numbers game. I think that we need systematic change within primary care in terms of how we value it as a society, and how we back that up with financial reimbursement, to be quite frank. I think that for a long time, our healthcare system has sort of undervalued or devalued preventative care. And instead, the way that we pay for our healthcare means that the more intensive or extensive the procedure or site of care, the greater the financial return for the institution, which is, something I'm sure that everybody here and listeners have come across and thought about. But I think that it will have to start with changes on that level, and then with more resources, I think that primary care systems would be better equipped to care for patients, and the stressors that we face as a system that is stretched a bit thin might be reduced. And so that includes many different staff, social workers, case managers, mental health providers, community resource specialists, administrative staff, nursing staff, medical assistants. More resources would allow us to better provide all of that wraparound care for our patients, because right now a lot of the onus of that care in certain places does end up falling to the primary care provider, whether that's an MD, NP, PA, and that can be overwhelming on top of sort of what we consider more strict, like, clinical work.
All right. Well, I think I'm going to send you back all off to cure people. I want to thank you, Dr. Rutter, Dr. Yu, Dr. Kaplan, Dr. Shah, and Dr. Bronthal for spending the time with me this afternoon. And I wish you luck in your careers, and your patients are all lucky. Thank you so much.
Thank you so much for having us.
Thank you.
That was our 296th edition. We come to you from the writers and editors of the NEJM Journal Watch series. Our executive producer is Kristen Kelly, and I'm Joe Elia. Thank you for listening.